From the beautiful Finger Lakes region of upstate New York, this is the Dental Lighthouse Podcast. We take questions from anyone in the dental profession and discuss what it takes to win not only in dentistry, but in life. Business, leadership, relationships, parenting, health and wellness, money management, nothing is off limits on the Dental Lighthouse Podcast. I'm Jason Tenori, your host, and have over 20 years of experience to pull from. Learn from my mistakes and let me help you collapse time so you can become the best version of yourself. Yo, welcome back. Dr. Jason here, Dental Lighthouse Podcast, and you are not going to be subjected to a solo episode today. You are not going to be subjected to my ramblings and to my musings and where you prematurely shut off the episode and go look for another podcast. The reason for that is because I am so excited to have Dr. Kalli Hale on the show today. Dr. Hale is a multi-practice owner. She is an expert in sleep medicine, sleep dentistry. I have known Dr. Hale and her husband for some time, just amazing people. She's done some mentorship in my organization for some of my associates, and I have just been itching to get her on the podcast and just have her share her wisdom with us and maybe collapse time for some of us that are a little bit more interested in sleep. So, Dr. Hale, welcome to the program.
Dude, I thank you for having me. I'm so excited to be on. I know it took a while to get here with our schedules, but I'm ready to rock and roll.
I'm excited. So, disclaimer, there's a lot of things that we can talk about with sleep. We can talk about, what type of appliances and how are you treatment planning and stuff like that. And I don't feel like this is the space for that, right?
Yeah. We
are possibly going to be blessed to have Dr. Hale come up to our beautiful Finger Lakes area sometime later this year and maybe give some CE on all the tactical, the granular details, right? The how. But what I would really like to do today is unpack the why. And, sleep is for me, and again, I'm talking from a position of ignorance. Sleep for me is like this black hole of, you read a blog and you're like, oh yeah, I think I understand it. And then you hear someone else and you're like, wow, I don't really understand it. So I'm just hoping selfishly for my listeners and for my team to unpack with you, Kalli, like where you got your start, why you became so passionate about it. And then most importantly, like what can we do as frontline clinicians, as screeners, to be more aware of everything that we can do to benefit these patients. So I know I just threw a lot at you there, but let's start with the beginning. Let's start with what was the motivation for you to kind of get into this space?
Oh gosh, I was going to say we could talk the whole hour on that, and I'm so honored to be on here to discuss it because one thing you just said a minute ago, where you feel like it's this black hole, we don't know how to treat it. There's hundreds of appliances on the market, and then we just kind of cocoon in and go back to our operatory and do our thing, and that's a really common problem. I have talked to dentists. Obviously, I do a lot of mentoring around this space who have spent 6 figures on airway training, and they're still not doing any airway cases, which was sort of my motivation for starting the Sleep Well Mentorship Group anyway, because I was like, where is our failure to launch here? Like, this is the most important thing we could be screening for in our practices, bar none. I would say ahead of tooth decay because of how serious it is. And none of us really know how to do it or implement it or talk about it, which was a big thing we needed to overcome and still do, I think, as a profession. But how I got into it is really interesting. So I graduated dental school and immediately was blessed to work in my parents' dental office. My dad just retired after like 47 years of practice last October, and he did a ton of implant surgery. Yeah. He was like one of the OG implant guys when it was like not looked at in high regard, which is very interesting. We have a similar path, but on different topics. We talk about that a lot, like where implant dentistry was in the 80s and where sleep medicine is right now, 2026. And there's a lot of correlations there. And I did an implant residency as well and was doing some surgery. And then I started hearing about sleep apnea, like an annoying buzzing in my ear, I'm like, I don't know anything about it. Then, if it was that important, they would have talked about it in dental school or whatever. And I had the opportunity to listen to some speakers around this space. And they started, the part that really hooked me in was on adults entirely, not pediatric, which is funny now given what I do, but it was like these problems we were dealing with in general dentistry, like popping crowns off, implant abutments coming loose, bruxism, making night guards, all of that had like an underlying root cause that I was like, I never knew anything about. Like, what do you mean? I mean, we blame ourselves, the clinician, when stuff like that goes wrong. If your implant crown breaks or comes off or whatever, and it's like, what is actually causing that to happen? And so I decided I was going to start screening patients. I did not have any sleep machines in my practice, and I didn't want any. I was in the headspace that if I referred you out for it and you did it and you eventually came back to see me, you were actually serious. And I had a very like weird, I would say cocky sort of opinion on it, right? And fast forward to now, we have over 100 machines, okay? Just to like condense time for everybody.
Okay.
And so I started screening patients, and the results that were coming back were actually very frightening. And I was catching severe sleep apnea in patients that would have never been tested. I mean, they didn't report any sleep problems. I'm just looking at their mouth and I'm realizing that things that we see every single day were actually proven to be symptoms of sleep disorder breathing, tori, abfractions, of course, bruxism. Nobody even argues about that anymore. And it's like, I was like, oh my gosh. And they used to argue about bruxism. Bruxism used to be a question mark in the sleep world of whether or not it was related. And it is. So it's like not argued anymore, really. But I just was like, well, now what do I do though? Like, I just caught that this guy stops breathing 40 times an hour. Like, I don't know how to treat it. I had no idea. Like, I was like, okay, go to your doctor, like, please don't die here in the dental office. Like, you need to have help. And so, yeah, it's just kind of funny how it all worked out. And I started learning and hearing about these dental courses. There's so many now. There are so many. Honestly, I take calls weekly with dentists that are just trying to figure out where to get trained, because it's like, who do you trust? Who has the best education, et cetera, et cetera. And so I went and listened to a doctor who was doing non-surgical expansion on adults, which I had the biggest attitude about. Let me just tell you, I was like, not possible. You're going to push the teeth to the bone. I want nothing to do with it. And I like showed up on the front row with a notepad, like I did in dental school all those years back, ready to just like go to town on this like presenter. And then each case was so compelling, and each pre and post CBCT, you couldn't fake that. Like this, to me, it's like, I was tired of hearing reviews, like Google review. I'm like, people could lie, you could buy them, whatever. This was like proof was in the pudding. And the pediatric part of that was absolutely life-changing. Like I was actually very upset when I sat through the first pediatric lecture on expansion to learn what I had been missing for so many years already and what was not taught in dental school to me. I was appalled. I did a pediatric rotation, obviously, throughout my dental training, and they were more concerned with if we were putting rubber dams on teeth for sealants than they were for us to identify if a child actually was suffering from hypoxia at night, which was going to change their IQ and completely alter the way that child was learned and grew and lived for the rest of their life. So I did a year's worth of flying to and from Denver to be trained, and was implementing it slowly that first year with patients that I really knew and trusted, especially in the adult side. And I started throwing appliances in kids' mouths like every day. Like I was going based on like your arch width should be this and whatever. And I'm measuring and I'm like, oh my goodness. And then I'm looking at sleep questionnaires, which we had never implemented in the practice. I mean, I went from no sleep to every single patient's going to fill out this questionnaire, and then starting more cases than I could keep up with, and which was 250 my first year of doing airway. I was just like, talk about drinking through a fire hose. I got to the point where I was like, oh my gosh, what am I going to do? Like, this is everybody. I had months on end waits for patients, and I was having Jason, tremendous success in the behaviors of these children, from ADHD to bedwetting to oppositional defiant disorder to just anything you could imagine that was symptoms of poor sleep quality. And I was just like unstoppable after that. I was like, I don't care what anybody says. This is like our most important job that we should be doing right now for children, because the orthodontics has not been done like that. And I have my own crazy ortho story. I've had ortho 3 times now because of the way it was done to me as a child. And so I have my own personal like biases too to how I wish things would have been done for me, given what I've been able to do for kids. So that was kind of a long-winded, like, how did I get, where I am now and how I started. But I think once you see it, you can't unsee it. And once you know that these symptoms in adults could be a literal cardiovascular risk, like they could go home that night and have a heart attack, and they were in your office and we missed it kind of thing. I feel a tremendous burden for educating to help dentists be able to do this faster than it took me to do in the practice.
That is flat out awesome. And, as you were talking, I was just thinking about things that I wanted to come back to. I know you kind of joked, but kind of didn't, talking about like a comparison to dental decay. And then in my mind, I'm like, yeah, maybe. But like at the end of the day, like being able to identify early on someone that has these signs and symptoms and being able to treat them, and the effect that that has on their life exponentially is more beneficial than, you know, decay getting into 30 and then possibly losing a tooth. Like, don't get me wrong, I'm a dentist, I'm in the business of saving
Same.
teeth, but who gives a rat's ass like if they lose 30 when we've
I love
completely
you.
ignored like their ability to grow and develop and you know have their brain. So I'm drinking the
Yeah.
Kool-Aid, right? I'm really
I mean,
excited. Just
100%. You couldn't be more right. And I argue, not argue, but I debate a lot about this when it comes to adult treatment, because the way we set up our ortho cases is very different, and it's beautiful. Obviously, everything's going to look really nice, but it's different than what you would imagine. And I've talked to some dentists that are so ingrained in this form of occlusion that they want to happen, which is retractive. And I'm like, okay, well, they can either breathe better or they can have the prettiest occlusion in the graveyard.
yeah, yeah. Which one would you like?
And that really is, I mean, it really is that serious when we're talking about patients who have had their teeth pulled, for example, and the entire oral maxillary complex is smaller, no room for their tongue. They're snoring every night. It's like, you're right. What really is the most important thing right here? And I would say it's oxygen.
Yeah. And to,
Bar none.
and to your point, like even if someone has like high blood pressure, you can kind of kick the can and be like, go talk to your primary care physician. You know, I do feel like we're great frontline screeners, but something like sleep, like you know, people have reported sleep apnea issues to me. This is 10, 15 years ago when I was seeing patients on a regular basis. And my recommendation was like, go talk to your physician. They go talk to the physician. Their physician would be like, I don't know, right? So like, who better
No.
to like, who
Yes.
better to be the
Yes.
quarterback here?
100%. And that is a big limitation for a lot of doctors that I talk to, is they really just feel like it's not like we don't have the ability to do it, or the permission really from the medical community. Oh my gosh, you talk to any ENTs, the second they know that you offer oral appliance therapy for an adult, they're sending you all their CPAP patients that they're tired of dealing with because they don't like their CPAP. They're more open to working with us than we realize, but we've always thought of ourselves as just the dentist. And until you can get
Yeah.
out of the mindset of being just the dentist, it's really hard for you to overcome that. And it's a big part of what I teach too, because it really is, it's so important. The collaboration is really important, and our ability to recognize who better to treat it. Who knows the face and the head and neck better than us? Like,
Yeah, no doubt.
you know, I mean, the appliances that we have to make are for their jaw appliances. Like, we have to be the one to manage it and understand how to do it. Whereas they can really only offer some pretty aggressive surgeries where they cut the soft palate out. It's called a UPPP. Doesn't have good efficacy. I've seen a lot of patients that have had that done. They choke a lot because you need your soft palate and your uvula, turns out. And Inspire, which is what kind of looks like a pacemaker. It's the newer sleep apnea device, or a CPAP, you know? And so that's what our physician colleagues can offer. And it's no better for children. Don't even get me started on what happens when you put a CPAP on a child. The retractive nature of that definitely affects the way their jaws are growing, because they're literally growing. So you're absolutely right. There's nobody better than us. I tell dentists this every day. There's no one more qualified to be screening and treating OSA than a dentist.
So the type A engineer dentist in me really wants to go down a rabbit hole and talk about the how, but I have to like, you know, remind myself that this is not the arena for that. So that, you know, kind of coming back at looking at it from 30,000 feet, I want to talk about two specific things, kids or adults. Okay. It's your call. The frontline hygienist, the frontline doctor, the frontline assistant, what are they looking for? What are they trying to hear from the patient that at least would like have that light bulb go off in their head and being like, I should probably ask more questions about sleep apnea. Or I should probably, what is the low hanging fruit here?
We'll start with adults first. And I will say the easiest thing to do is to just implement the sleep questionnaire with your intake forms. That's going to be the easiest, because it's going to ask a slew of things that you could just literally look and say yes or no to, and ask the patient more questions regarding those answers. But I think if somebody's not implementing that and they've never done it before, the things that you want to look for are the things that you're already telling your patients they have all the time. You just don't know it's linked to sleep disorder breathing, potentially sleep apnea. So bruxism, like we talked about, number one. I mean, I don't know how many bruxing patients we see every day, but it's a lot. So anytime a patient has signs of that, even though they love to deny that they do it or whatever, and we can show them with our digital technology, I just love to ask them, how is your sleep? Like, tell me more about your sleep, because your mouth is telling me hints that you might be struggling to breathe at night, and I don't want to be the one that misses it. And so I just create an environment that we can talk about. And he's like, yeah, I mean, I think I'm okay, or I get up a couple times to pee at night or whatever. Bruxism is one way to open the door. The other is is tori. I used to tori all the time. I had no idea that tori was a symptom of sleep disordered breathing until I got educated in it. And it's just linked to that clenching pressure we know that happens when the body starts forming more bone. But the fact is, why is it doing that? And if you understand the mechanics behind the jaw trying to come forward, it's like self CPR. That is what they're finding when they do sleep studies. There's some cool ways that they can test this, but they will put a PEZ down somebody and it'll tell them the muscle activity of the tongue, and they can account for bruxing while they're sleeping. And they see the patient go apneic, stop breathing, and it has to be for at least 10 seconds for it to even record. So this whole apnea event is happening. And then they wake up and they brux their teeth. So it's their way of literally opening. When you put your jaw forward, you move, you're going to move the base of your tongue, which is how that Inspire implanted device works, by the way. It just activates the hypoglossal nerve to push the tongue out. So that tongue is the problem. And that's part of the assessment. So if I see tori, if I see bruxism, the other would be clinically just narrow arches. Like I could give people numbers all day. And I think numbers is good. The dentists are type A, they like numbers. I will say an arch width less than 33 millimeters on the lingual between 3 and 14 has a higher propensity for severe obstructive sleep apnea with time. So you can take just that and know that this patient's already at risk with no other symptom besides the arch width being narrow, which I think is really important. It's really important when you're talking about how to treat kids, because you definitely want to get them wider than that, obviously. So the other would be abfractions. TMD is a big side effect of sleep disorder breathing too, and oral appliance therapy actually helps with that. I take calls with doctors that are worried that if they put somebody in a MAD, that's going to exacerbate the TMD, and that only happens 10 to 15% of the time. So you got to know what you're doing, obviously, but really you'll help them ultimately, because if their TMD is from malocclusion, fix the malocclusion. But if it's from the muscles being tight from clenching, this is going to give them a ton of relief. So those are kind of the top ones. Daytime headaches. Oh, the other big one would be hypertension. We take blood pressure on every single patient that walks in our office. It's law, right? And if they have hypertension, they probably have sleep disordered breathing. So that's an even easier one. If you see them and they're always that patient that like has to get rescheduled or isn't taking their meds, or maybe they are taking their meds and their meds are getting upped with more meds, because that's all the physicians can offer is yet another medication. And that would warrant a sleep study all by itself as well. So those are my big ones for adults. I would say hypertension, bruxing, tori, abfractions, and reflux. Reflux is another really big one. So the reflux connection. Go ahead. Do you want to say
No. I was going to say, so you're seeing these signs, you're seeing these symptoms, like you know that they're predisposed or they're currently going through apneic events. Is there like sometimes with adults specifically, they may have a clinical sign or symptom, but it's not bothering them. They're not worried about that. Like, is there like a question or a hook that you're asking adult patients that find them to be more interested in pursuing treatment? Like, is it a sleep related question? Is it like, how are you feeling in the morning? Is it like, are you restless at night? Like, what is the what's the sizzle to the steak? Yeah. Like, how do I want to be able to say to someone like, and if we treat it, this is how it's going to change your life, as opposed to like when you treat decay, they're like, I don't care. You treated decay. Like what, but how is this going to affect them?
Yeah. So the cardiovascular risk and the stroke risk is really, really high. And I personally hate to treatment plan out of fear. I don't advise the doctors that I train do that either. Nobody likes to be scared into a sleep study. But the fact of the matter is if you have somebody that you know has OSA just by looking in their mouth, the burden and onus is on you to get them to say yes to that sleep test. It really is that important. So if somebody has a previous history of any sort of cardiovascular event, they don't want that to happen again. They are concerned about that. And, oftentimes, obviously they survived it, but they're maybe on medications, whatever, blood thinners. It's just important to be looking at it as a whole. And so for me, I like to use their history. I always ask, how do you sleep? That's my first thing is, hey, I'm noticing some sign in your teeth that you brux or whatever. Let me know, how is your sleep? Because this can be really linked to sleep disorder breathing or sleep apnea, and I really don't want to miss it. Can you give me some insight to what your night looks like? And most of them are just like, oh, it's interesting you're asking me that. Like, sleep like crap. I'm tired all the time. Like, most of the time you are going to get an answer that you're like, oh, I'm really glad I asked you. Not just like, no, I'm fine. Like, what are you asking me about this? People are worried if they've owned practice for years on end that a patient is going to actually be upset that it's the first time they're asking them that. That's never happened to me. Like ever. It's always, and if I ever got that inkling, I've told doctors, just tell them how lucky they are that you're literally doing continuing education, that this now exists in this arena, and we are the frontline ones to screen for it. So If they've had any previous history, that is a really easy opening into the conversation. The other is I tell them plain it, like if I feel like they're not catching what I'm pitching or whatever's happening, I look them dead in the eye and I say, listen, if you have sleep apnea, whether I help you with it or not, you need to know. And so I just pull myself out of it. Like, you don't have to come to me. You can go to anybody you want. You don't have to do anything, but you are going to want to know, because the lifelong effects of that are really scary. And so I do say that. And I think after thousands and thousands of home sleep studies done, they're really worried that they're going to get a CPAP. And I figured that out finally, because I'm like, the resistance sometimes to like wanting to know, I get it, but ignorance is not bliss when it comes to OSA, is they don't think there's another option. Like they're just like, I'm not wearing, the number of times I've heard them say, I'm not wearing that mask on my face. I'm like, good, because I can't even give you one of those. That's not even my line of work, you know?
Right.
So anyways, if that makes sense. Yeah.
Yeah. Awesome. So that kind of, from my perspective, wraps up adults. Walk me through some of the kids, adolescents. I'm very curious on the signs and symptoms. Like when I was taking a lot of sleep stuff, the number one sign was bags under the eyes. But if I'm hearing you correctly, there's just a number of other things that we should be looking out for.
Yes, there's so many. And venous pooling, what you were talking about, the allergic shiners, those are still top of the list. They're not, you know, I see them so often now. I'm like, show me a kid that doesn't have them at this point. But the pediatric, this is really important. So the pediatric sleep disorder breathing discussion is that it's a spectrum. Okay. And this is what Dr. Mike DeLuke, incredible orthodontist out of Florida, a good friend of mine, he wrote an article in OrthoTown that said it so eloquently. Sleep disorder breathing starts with mouth breathing on a child and ends with obstructive sleep apnea. The last thing you want is to wait until it's obstructive sleep apnea. You're rarely going to have a sleep study on a child that shows an apnea index worth treating. Rarely. Because the kiddos don't desaturate to that point. They just naturally are not. They're going to wake up a ton and have hyperactivity and all this other stuff. But you do not have to have a sleep study on them. And you certainly should not rule out treatment based on a negative sleep study, I guess is my point. So with that spectrum, it starts with mouth breathing. Then that mouth breathing turns into bruxism. We see that a lot. I mean, I would say pediatric tooth grinding, like parents are telling me they're hearing the kid outside the room. Like that is never normal. I was taught to tell a parent that was normal and they'd grow out of it. I don't know about you, but that's literally what they told me about grinding and snoring. And I'm here to tell you there's no evidence to support that. I don't know how that got into the pediatric literature ever, because it's false. And a snoring child turns into a snoring adult and a tooth grinding child turns into a tooth grinding adult, period, until proven otherwise. So when you have mouth breathing, snoring, and tooth grinding, you're already leaching towards obstructive sleep apnea on that spectrum. The other would be behavior. So I treat a lot of behavior issues in children. So ADHD is so correlated to poor sleep quality. The constant disruptions, they're never fully through their deep sleep cycle. Their REM gets messed up. It's just their desaturations of oxygen are worse during REM, and their poor brains are just on fire, honestly. So, and the misdiagnosis rate is upwards of 50%. So I am uber passionate about having these children screened somehow with an airway dentist or at minimum a sleep study before they're put on mute-all-tree medications. Because what's the end date for that? And what are we actually treating? You know, with ADHD, it's always like, oh, you were born with it. It's some sort of genetic thing. And it's like, that's actually not true. But we've heard it for so many decades now. I mean, that ever changing is going to take a ton of work and a ton of effort. So those are the most important. I would say behavior issues with children, struggling in school. I mean, teachers have a front line. We're constantly educating teachers in our communities because I'm like, you guys have a front line with a kid falling asleep in class. Like, that's not normal. They shouldn't be. And teachers have told me, yeah, they fall asleep and they're snoring at their desk. And like, they shouldn't be having any sort of, like, the breathing should be silent. So from the dental perspective, there are symptoms that very much mimic adults. So grinding, snoring, mouth breathing. The kid will be in the chair and you can just see all the boogers and they can't breathe through their nose. And the mom thinks they have allergies and they might, but that's totally going to change the way they breathe. And if they're not breathing through their nose, their whole cranium is not going to expand naturally because that's the tongue's job. So one way you can know whether or not a child is on track is to do an arch width measurement, which we do on every child, kind of like I was talking about with adults. And there is a minimum that arch width should be at age 4 and then 8 and then 12 and then 16. You'd be shocked. What you're supposed to be at 12, which is about 40 millimeters, you're never going to find that with that intervention now. Like, really. And I'd be impressed if you found an adult that was actually that wide. right now
Okay.
because of the way
Wow.
ortho was done. So that's such an important part of it, and just making sure that these kiddos are obligate nasal breathers and they have room for their permanent teeth. So we're not waiting till they're 12 and then extracting because we told them to wait, and we've been telling generations of kids to wait. And yeah, so those are the big ones, I would say.
When you notice these signs and symptoms in your pediatric population, is the same next step a at-home sleep study, or is it different for kids than it is for
You don't
adults?
have to. Yeah, which is kind of nice because you can, like I said earlier, it's difficult sometimes on the kids to get proper data. And if you're only
Right.
looking at the apnea index, it's not going to help you anyway. And so what we're doing with kiddos is orthodontic. So, and I love to say, we're bringing them back to normal anatomy, which is a lot of what airway orthos will say. And so we don't need, a physician's like permission or a sleep study or any of that to recognize that the arches are too small. And you just have to know how to fix it at that point, And so we look at it from that perspective of we can do a sleep study. And I do on older kids that are really suffering because I love my data. So I love to have a pre-sleep study and show it's all gone at the end because they do a lot of lecturing. But on the little kids, you don't have to do that. Just fix it. Just get in and start expanding.
And that's the number one thing, just expansion.
Yes, 100%.
Yeah.
Myofunctional therapy comes up later, but expansion and the guidance appliances that you guys are doing in your offices as well, gold.
Are these expansion appliances? And again, we do have some providers in my group that do it, and I'm a few levels removed. Is it primarily fixed appliances?
Yeah, you can do either. So the way I teach this is we use these prefabricated myofunctional appliances that look like the brands would be MyoBrace, Thevos Guides. I'm not sure if you're familiar with those, but those appliances do a lot. Okay. When it comes to the musculature with great promoting the tongue, go to the roof of the mouth, and also slightly bringing the jaw forward. So it is like epic for your class 2 deep bite kids. I mean, it will correct in months, like so fast. And so I teach on those as a first line defense right out the gate. They should be leading with that. It helps patients with providers to know what their first step is for case acceptance, and the patient leaves with that day. And then we build the custom expanders. I like to have a couple of months with these myofunctional habit corrector appliances. And then we build fixed or removable, actually, expanders, upper and lower.
Is when you treat a child, a 7, 8-year-old, is the goal like cessation of these signs and symptoms, where with adults it's more management? Like, can you fix an adult? It sounds like you can fix a kid through expansion, but can you fix an adult, or is it just management of their symptoms, which would ultimately lead to a better life?
You can fix both. I'm here to tell you can fix both. Yeah.
Wow.
The children are the easiest to fix. The children are the most predictable, the easiest. Ask anybody because they're growing. You get to go faster and the results are just like so rewarding. With adults, our non-surgical techniques, I have cured people of severe sleep apnea. I have. Like they've gotten off of CPAPs and they're on with their life. It is beautiful. And there's also some great providers offering surgical services for this too. Double jaw surgery. Dr. David Alfie is like the king of that here in Houston. He does it in 2 hours and you're done. MARPE, it's an implanted expander in the roof of the mouth for adults. And patients that want that, we refer that out. But we're doing mostly non-surgical on adults very slowly, very predictably. And not everybody is cured, of course. If anybody tells you that, regardless, even with surgery, they're lying to you. They haven't done very many if they're saying that. But none of the patients have ever gotten anything but better as far as their dental health and the expansion. The mandibular advancement devices for adults are sometimes people's adults' retainers, just FYI. So if we've done Invisalign or we've done non-surgical expansion, they might still sleep with their jaw forward at night, and that would be considered management, like you're saying. With the kids, I demand perfect. I really do. I want to leave no stone unturned. Whether once I get the jaws wide and I know there's nothing else that needs to happen skeletally for them, then we're looking at the nose. We're looking at tongue ties. They're in myofunctional therapy, which is like a branch of speech therapy to work those muscles and make sure that they have a tongue strong enough to suction to the roof of their mouth while they're sleeping at night. So we really like collaborate a lot with ENT, sleep physicians, things like that. But the majority of what's happening for the pediatric patients is in the dental office.
Awesome. I want to talk about two sets of action items for people that are listening, for people on my team that might be listening to this. The first set is awareness. So you referenced this questionnaire I'm curious, is the questionnaire one that you've internally developed, or is there an academy that's like the accepted expert that has shared this questionnaire?
Yeah, no, there's definitely not a governing body, but there's an expert that has developed this. I think it came out of Michigan, actually. Michigan's got a very good dental school and a very good sleep education. There is a new one being formed by a lot of my really close friends and colleagues that I've been honored to be a part of, that I think will be probably the new standard. But the pediatric sleep questionnaire that we use has been around for a long time. I don't get the credit for it. I didn't invent it. It's called the PSQ. And that's what I would say 99% of us are using for screening. They have an adult and a pediatric questionnaire. So anybody can download it.
So Monday morning, if there's clinicians, frontline screeners that want to like start making a difference, it's getting the questionnaire filled out and it's looking for these clinical signs and symptoms that you have been alluding to over the last half hour. Is there anything else that they can be doing to identify a possible condition or create awareness for the patient?
That's the questionnaire is going to be the easiest for them because they need to know what to ask, but then they also need to know how to talk about it. And that's where education programs like the one I have help a lot, because you go into detail. Like today we're talking about the why, but we can talk about the how, and we will hopefully in the fall. And that's going to be the thing that I think really brings them across the line. The ADA asked us in 2017 to start screening for sleep. Okay. We keep the position papers in all of our locations. The problem with that, even though I loved it, the problem was nobody knew how to do it. Nobody knows anything about sleep test machines and which ones to buy and how to interpret them. So while they meant well, it left this gaping hole of every dental school in the United States almost that doesn't talk about sleep, and all those professors that can't talk about it and never did it and all of that. So it's just, we're behind. So having those conversations and recognizing that if you can get them to take sleep study home, then you're talking about it right. So I would say have the questionnaires for sure, but then consider having a machine or two. They're so easy now. You don't have to have all these disposables and all these crazy $5,000-$6,000 sleep machines. Ours are $300 a piece, and it's a big ring. They work beautifully, and as you guys know, in y'all's offices. So if they can do that and they can get somebody to do the sleep study, and then they get the results, we're like, wow. So this is correlated. This bruxing is sleep apnea, or this tori is sleep apnea, and it'll help them a lot.
So the frontline person who maybe doesn't have the support of their dentist yet, but who's listening to this and they want to help these kids, they want to help these adults. They've identified that this person is this kid's more than likely to have sleep apnea. If they can't lean on their own dentist because he or she's just not there yet, is an ENT the next choice? Is a pediatrician the next choice? Like, what would you encourage these clinicians to do next?
Yeah, that's hard, because I'm thinking like, oh, I would hate it if my hygienist was having to go around me for something, but this happens. This is very true. If we're talking specifically on your like RDHs, I would say, or even an RDA that's passionate about it. So selfishly, I would say they need to go to toothpillow.com and submit for a virtual assessment, because that's why I created teledentistry company, to have these kids be assessed and screened by an airway dentist in their state. We're in all 50 states. So they can literally go online and fill out the form and put their pictures in, and they're going to get an answer as to like if they need to go in office and where. Otherwise, I would just be encouraging the parents to get on social media platforms that are posting a lot about this. There's some great podcasts. I mean, there's so many people now, which is so different from 10 years ago, talking about this. I mean, the daggers I had in my back, the orthos that stopped talking to me 10 years ago, Jason, I'm not even kidding you. It's like now everybody wants to be educated, which is great. Yeah. I'm fine. Like, it's fine. Yeah. But it's a different world now. I mean, my Instagram has got tons of educational content for doctors and patients to see before and afters. So I would just encourage, ENT, to answer your question, very, very good profession. They're not dentists, though. They don't all know about expansion in pediatrics. Their go-to is going to be removal of tonsil and adenoids, which is fine if they need to be removed. But we have evidence now that maxillary expansion shrinks them statistically significantly, like up to 87.5% of their volume. And so that's where I'm like, I don't know if I want to like suggest removal of those unless they really need it. So I would just encourage them to maybe send a tooth pillow or DM me and we'll help them find somebody. But
okay, I love it. What about when the dentist that hears this and he's like, you know what, it's time for me to start not only recognizing it, but start to be able to treat some some basic cases? Like what is the next step? Is it a virtual course with you? Is it an in-person thing? Is there a continuum somewhere? Like
Yeah.
where do these people get educated to really make a difference?
Well, I mean, I would love to be at the forefront of it for them, obviously. And I have a virtual course that they can take. We're also going to be in October in San Antonio for Dental Life. I hope you and your whole team are going to be there. I don't know if you've seen that one yet, but it's going to be awesome. And Kyle's hit me up right now to do some sleep stuff the day before. So I think we're going to offer some good training on that. So I think whether you want in person or virtual, the virtual platform for me has been awesome. I trained a lot of dentists that way. And after that, though, the ongoing mentorship is where I think is really needed. And the funny story, when I started the Sleep Well mentorship group, I never intended on teaching sleep. I never intended on having an all-day 7-hour sleep 101 because my target dentist was the one that's already paid for all that, but just needs help to know how to do it. And then I had so many people asking me like, well, can you just teach me how to do it, that I made that. So I have the virtual course. We also have ongoing mentorship options for doctors, which I'm doing now for over 2 years. And I have some of the same ones that have been in from the beginning. It's just been awesome fun for me. Like it's really
That's awesome.
So
that's awesome.
Yeah.
I don't want to take up a ton of your time, but I do have the entrepreneur in me has to make this point. So here's the deal, right? I do a lot of coaching, and I'll encourage one of my clients to expand their skill set. Maybe it's implants, maybe it's Invisalign, maybe it's sleep, right? And the scarcity mindset is, well, my patients don't need that, or my community doesn't want that. So a little bit of a humble brag for yourself. Can you just talk a little bit about what you're doing in your group from just an airway perspective, right? And how it's grown, and you're struggling to even keep up with the demand. So for people that are like, I could only probably start one case a month, right? Like just spend a little bit of time,
Yes.
just spend a minute, give me the elevator pitch on what you and Kyle are doing with the locations limited just to sleep, and how it's kind of blown up on you.
Yeah, I would love to. So when I started Airway at New Teeth, which was our GP practice, it was just me in the trenches doing all of this. And I realized that the problem was so much bigger than me. And I tell you what, Jason, I've talked to dentists who said like, well, in my zip code, I would have done what I did in any zip code I was ever in. There was no stopping me once I realized how important it was. And so I work a lot with these doctors to just talk to them about their mindset, the story they're telling themselves, which I'm sure you do too. The story that they're telling themselves is limiting them in life, like in every aspect. Like, and part of my story with burnout and writing the book and all that too was going through it myself to realize that there was nothing that I wasn't going to be able to do if I could just figure out how to shut up my brain and start doing it. And so we had a bunch of dental offices in the beginning, sold that group. And Kyle and our business partner, Matt Hicks, who's faculty for Invisalign, an absolute wizard when it comes to clear aligners. We were talking about going into practice together, and Dr. Hicks really wanted to open an ortho-specific group. This is pre-airway dentist. And I was just letting Kyle and Matt kind of figure all that stuff out. They're the business guys. I'm just over here saving kids and in the trenches working. And Kyle finally came to me and he was like, okay, we want to do this. And, he wanted me to be involved. And I said, if you don't call it the airway dentists, it'll be the biggest mistake you ever made. Because they had some names and stuff for it, And I was like, the only name is the airway dentists. And it will be the thing that if you build it, they will come. And you just have to trust me. And I think he and Matt were both, God, I don't know. The airway dentist, like, people are going to wonder what it is. And I go, that's exactly right. And that's exactly what you want, is for them to wonder what it is. Instead of calling it something else and then trying to tell them you do sleep, this is going to be obvious. And so we opened the first 2 locations about, 9 months apart from each other, and one in Sugar Land, Texas, and one in Friendswood, Texas. And they were like the biggest learning curve, obviously, of the 2 of this model. And they're both massively successful. I'm so honored. And we learned a lot along the way. And we brought a CEO in beginning of last year. And we are now almost at location number 10, what I was talking about earlier. And one of the ones that opened most recently in Austin, Texas, had 180 patients on the schedule before the day of opening. So she walked into months booked out. Okay. In a brand new town. I wish I've literally not stepped foot in that office, just FYI. I have not even had time to go and be there. And so we have seen that time and time again. What we have built with our pre-marketing and the collaboration with physicians in each of the towns, obviously it's not the Kalli show. I could literally not do this if we didn't have the team that we have supporting me. But if you build it, they will come, and you absolutely can do this in your practice. There's nothing stopping you but you.
Yeah, amen. But I mean, just to your point, the mindset is everything. It's just, you believe what you believe. And and
Yes.
for you to have 10 locations, like, and the 180 scheduled new patients before the doors open. I mean, it's just ridiculous. It just screams what the consumer wants. And
Yes.
and I don't
Yeah.
think that, to your point, I don't think that's zip code specific. All right. I'm sure lots of people are going to want to learn more about what you're doing and how they can somehow, ride your coattails and be associated with you. So give me some websites, give me some contact info.
Yeah.
Give me the lowdown.
Well, we are always looking for good dentists to join us. We're opening rapidly. So if you want to apply, you can go to the airwaydentists.com/careers. We have a application page there. We'd love to talk to you. We'd love to interview. We are very picky. We want the best of the best, but I can teach you everything. So if you are kind and empathetic and an ultimate good person, the rest of it's going to be easy. And I look forward to doing it. My Instagram is the Airway Center Dentist. I'm constantly putting out information on there. It is a good platform to know what's up. I post articles that are new and, all sorts of good stuff like that. So I would say Instagram, and then the sleepwelljourney.com/mentorship is how to learn more about working with me. I'm very picky about who's in the mentorship group, and they all are on an interview basis. So we would meet together and discuss what your needs are to see if I can help you with them or not, and go from there. I will be at Set No Limits in October, which is through Dental Life. You guys are one of the first offices to ever be associated with Dental Life. We're so excited for this epic event they're putting on in October. So I look forward to seeing people there.
Well, so I love the pace that you talk. It's very similar to me. So, but I missed the last website address. Can you just slow down and say the mentorship one? Can you just slow down and say it again?
Yes. The mentorship one is the sleepwelljourney.com/mentorship.
Okay.
Yeah.
The sleepwelljourney.com/mentorship. Got it.
Yeah.
Awesome. Anything else that we should cover before we sign off?
No, but this was just way too fast. We have so much more to talk about.
I know we're going to talk about it. We're going to talk about it in the fall. We'll probably do another podcast on the how, and then we'll have you come in and we'll just like blow people's minds with how to implement this stuff. And
I know, I can't wait.
We're doing our part.
Yeah, we are. Thank you for having me, Jason. I appreciate it.
Ladies and gentlemen, Dr. Kalli Hale.
Thank you. That wraps up another episode of the Dental Lighthouse podcast. You have a choice today. Choose to be a lighthouse. Lighthouses are powerful and steadfast. They are beacons of light for others to reference when life gets turbulent. Go out into the world today and become a lighthouse for someone. Give more than you get. True joy comes from serving others. Start today. I'm Jason Tenori, your host. Thank you for listening to the Dental Lighthouse podcast. For more information, podcast show notes, or links to anything that we have discussed today, please check out our website, thedentallighthouse.com. We would love to hear from you. If you would like to get on the show, please email us at podcast@thedentallighthouse.com.